what I'm going to talk today is to start with about the physiological changes in pregnancy. Now, so we are going back to the basics in physiology as well as some part of the pathology as well. So, functions of the kidney. Now, kidney acts as it has many roles in equilibrium of the body. So, it mainly acts as the salt and water balance, and also it adjusts the acid-base balance, and also it helps in the vitamin D metabolism as well as some other ions like calcium and phosphate. And the main function of it will be the elimination of nitrogenous waste products like urea and creatinine, and also production. It acts as endocrine organs by producing erythropoietin and renal. So those are the main functions of the kidney. And if you are to look at the anatomical basis, because I thought this would be important for you to understand in the rest of the symposium when we talk about the renal diseases. So the functional unit of the kidney is the nephron. Now there are more than 1 million of nephrons in each kidney. There are two main types of nephrons. One juxtamedullary nephrons and other one is the cortical nephrons. The juxtamedullary ones are the longer ones with the longer loop of Henle. I am sure the train is, if we can recall this knowledge from our part 1 knowledge. And so the function will be the glomerulus will start filtering of blood. The glomerulus will get the blood from the afferent arteriole, and it will be out from the glomerulus from the efferent arteriole. So this filtrate is then modified in the tubular system. The tubules has the proximal convoluted tubule, loop of Henle, and the distal convoluted tubule. So there will be reabsorption as well as secretion of solutes into this. So it will get modified and final outcome will be urine. And the kidney has around 1.2 liters of blood flow. This is non-pregnant blood flow, and the general glomerular filtration rate will be about 120 milliliters per minute. Now this GFR is considered about 10% lower compared to the males. In females it's lower even if we correct for the body surface area. This is mainly proportionate to the body surface area. So that is the basic knowledge about the functional unit of the kidney. So if we slightly go into a little deeper knowledge on the glomerulus filtration. Now I talk about the afferent arterioles and the efferent arterioles. So this filtrate has to cross mainly 3 layers. So it has firstly the capillary endothelium, and then there is the basal lamina, and there is a tubular epithelium. Okay. So the afferent arterioles, now there are epithelial pores in this afferent arterial capillary endothelium. Now these pores are, although they are larger when we actually see under the microscope, around 25 nanometers, but they are functionally does not secrete anything more than 8 nanometers. So they will, whatever the substances has to, the filtrate has to be, any substance has to be less than this. Okay. So technically, but although it's 8, most of the time their filtrate is less than 4 nanometers. So that is one aspect. So the pore size decide on what are the substance with filtrate. The other factor is the proteins in the capillary pores, the xyloproteins are negatively charged. So anything negatively charged will not filter, but it will kind of a repellent action. So we know that the albumin is also negatively charged. So although it's a smaller molecule, it does not normally filter through these capillaries. So therefore there are no cells or protein in this filtrate. So that is the about the glomerulus. So don't forget about the pathology knowledge in the glomerulus. So if you see a microscopic cut section, now concentrate on slightly on this green cells and the purple cells. Green cells are the pseudopodocytes. So they have something called fingers called pseudopodia entirely covering this capillary tuft. So they covers, and in between these pseudopodia there will be filtration slits. So the gaps are function as the filtration slits, and then you have the purple color cells in between. Those are the mesangial cells. Now they can contract the glomerulus as well as relax. So it also can control the amount of filtrate. So these cells are important in generating the filtrate. Then we have the tubules. I said previously, proximal cannular tubule, distal loop of cannulae, and followed by the distal cannular tubule and the collecting duct. So you can see different ions and other substances are reabsorbed or excreted or secreted into the lumen. Okay, so what are the physiological changes? Now I am going to discuss this in four main: structural changes, glomerular function changes, tubular function changes, and the endocrinological changes. So what are the structural changes? So because of the renal blood flow increases, the kidney get edematous. So the bipolar diameter will increase about 1 to 1.5 centimeters by about 26 weeks. Then so because of that, the kidney volume also increase about 30%. So when we do the ultrasound scan, the kidneys might look edematous. Then there is a condition, we call it physiological hydronephrosis. We know when we get the ultrasound report of a pregnant mother, most of the time we get the reports as hydrouretus and hydronephrosis mild. So this is because of this increase in mechanical increase in the size because of the increased blood flow, as well as there is some obstruction from the gravid uterus to the ureter. So there will be some pressure developing in the ureters, and also there is smooth muscle relaxation effect, we know, because of the progesterone. So there can be urine stasis, especially some postcoital volume, and asymptomatic bacteriuria sometimes can lead to symptomatic cystitis as well as pyelonephritis if it is untreated. That's why we treat asymptomatic bacteria in pregnancy. And also increase in urine frequency is a common complaint that we hear. That is because of the lower segment of the uterus or the fetal head having a compression. Then stress and urgency incontinence, although they are not structural changes, those are common complaints that you might hear. So you can see the hydronephrosis, and you know it's more in the right side because the right ureter crosses at a more acute angle through the vessels in the right side. So you commonly see it's on the right side. Okay, so glomerular function changes. This is the main change, that is the glomerular filtration rate increase more than double. So it even in the luteal phase before pregnancy, because of the effect of progesterone, we will observe the GFR increase about 10%, and this peaks around 16 weeks and maintain, and at the third trimester it come back to about 45% above the normal level. This is mainly because of the gestational hyperfiltration mediated by the progesterone and relaxing on the smooth muscle. So what are the effects of hyperfiltration is fall in the serum creatinine. You will observe from about 72 to about 54 at the second trimester, and gradually rise but not coming to the normal level. Now, so this is important because sometimes serum creatinine level can be falsely negative even if there is some glomerular dysfunction. And there's gradual rise in proteinuria, but not to the abnormal level, but usually it increases from around 150 to close to 250 level. And also there will be albumin level, serum albumin level will be dropped. So about proteinuria, because that is the most important thing. So non-pregnant proteinuria level is around 150 milligrams per 24 hours. I am sure nephrologists might talk about this more in detail. So the proteinuria increases, I said, to about 200 to 260 level because of the increased GFR, increased capillary permeability, and also decreased tubular reabsorption. But we consider it's abnormal if it is more than 300 milligrams per 24 hour excretion or UPCR more than 0.3, that we all know. So quantification is best done on 24 hour excretion, but UPCR also can be act as a guide. And what are the tubular? Now glomerular function. Now secondly the tubular functions. So excretion of substances like bicarbonate are increased because there is respiratory alkalosis. So as a compensatory mechanism, increase in the bicarbonate excretion. Glucoseuria, I will touch it bit on detail. And calcium excretion increase about 250 to 300 times during pregnancy. And also there is more sodium retention, and this is happening because sodium retention, and also there is ADH level, also osmotic threshold for the antidiuretic is released, so there will be more ADH release, so there will be water retention and edema in the body. Although there is sodium retention, there will be sodium level will be low because of the water retention and osmotic dialysis. So about the glucose is actively transported into the cells by the sodium dependent glucose transporter. Now this is a sodium potassium ATPase pump dependent mechanism. So almost all the glucose is reabsorbed into the through the filtrate. So there is a renal threshold for the glucose reabsorption. So until 180, roughly about 180 milligrams in the venous plasma, all the filtrate glucose is reabsorbed. But if it is more than that, then it can appear in the urine. So pregnancy and glucoseuria is the GFR is increasing, so amount of glucose coming can be more than 300, more than the transport maximum. So even in the physiological state, the glucose can be appear in the urine. But if it is persistent, might have to secondly screen for GDM. Now renal endocrinological changes in pregnancy are mainly increase in renin. Now all these are adaptive mechanisms. So increased production of renin causes renin and aldosterone system to increase the volume. But now this is a compensatory mechanism for the vasodilatation happening to prevent blood pressure drop. Now there is twofold increase in the erythropoietin secretion, that is to keep up with the hemodilation occurring. But although there is twofold rise, still there is some amount of hemodilation causing a hemoglobin drop, especially around 26 to 32 weeks. Then there is activated vitamin D level increases. Now we discuss about the calcium excretion increase about 300%. So to keep up with it and also to keep up with the fetal needs, there will be increase in the activation of vitamin D3 in the kidney. So these are the main endocrinological functions. To sum up, so there will be a gradual rise in the GFR up to about 55%. That's because of the increase in the renal blood flow. So this hyperfiltration results in excretion of substances which were normally not excreted, like glucose, protein, and other substances like calcium. Then glucoseuria in pregnancy can be normal. Proteinuria, however, more than 300 milligrams per 24 hours is abnormal. Now there is a significant drop of serum creatinine which might need to keep in mind when interpreting results in pregnant patients. Serum albumin level also drop, and sodium retention will be there, and because of that water retention and edema develops, and secretion of renin and erythropoietin active vitamin D3 increases to keep up with the increased demand, and there are anatomical changes in the kidney that can mimic obstruction. So that's what I need to tell you about the physiological changes in this 15 minutes. Thank you. We'll go for the discussion later.